Hello students, today we will discuss about pneumothorax and pleural effusion. Pneumothorax and pleural effusion, they are actually not diseases, but they are the sequelae of different diseases. Pneumothorax is presence of air in the pleural space and it pushes the lung to one side, as you can see in the picture. That there is a dark colored air which is compressing pink lung. Now, what are the causes of pneumothorax? It can be idiopathic. It means that it can be without any reason, or it can be because of underlying lung problem like underlying chronic obstructive pulmonary airway diseases, tuberculosis, asthma, or it can be iatrogenic. For example, when you are passing CVP line or double human catheter, you can accidentally enter into pleural space. Then it can be because of any trauma, and it is also associated with Marfan syndrome. Now, what are the signs and symptoms of pneumothorax? It can present with chest pain, shortness of breath, and if pneumothorax is huge, then it can also cause hemodynamic compromise. Means that the patient will have no blood pressure or no pulse. He will be BP-less or pulseless. As far as the signs are concerned, there are decreased chest movement, hyper-resonant chest tone percussion, decreased vocal resonance, and decreased breath sounds. Other than this, we can find tachypnea and hypotension in case of tension pneumothorax. Now, how do we investigate pneumothorax? The primary investigation is X-ray. Here you can see that in the area which is on the left side of the lung, we can see a big black arrow showing air. Now, this is the X-ray of tension pneumothorax, where you can see that in the left side of the lung there is jet black air, and it has pushed trachea towards the other side, and the heart also towards the other side. So this is tension pneumothorax. Now, how do we treat pneumothorax? If it is primary pneumothorax, means that patient has got no underlying problem and it is of small size and minimal symptoms. We have got three management strategies. First is observation of the patient. Second is ambulatory device, which acts as a one-way valve, and air is sucked inside and is not allowed to return back. And third is needle aspiration. And after doing all these, we follow up the patient either in outpatient department or we observe the patient within the ward if it is secondary pneumothorax but with minimal symptoms. If patient has got symptomatic pneumothorax and is of large size and it is with hemodynamic compromise, or if the patient's age is greater than 55 years, or he has got hemopneumothorax, that is blood also in with the air mixed with the air, or bilateral pneumothorax, or underlying lung disease, or you have attempted previous needle aspiration because of primary pneumothorax but the attempt has failed, then we go for chest intubation. Second topic is pleural effusion. It is the presence of fluid in the pleural cavity. So basically pleural effusion can be categorized into transudative and exudative variety. In transudative variety, we have causes of cardiac failure, causes related to liver, for example CLD, or causes related to kidney, for example nephrotic syndrome. While on the other hand, in exudative form, we have got infections like tuberculosis, pneumonia, empyema, and we also can have malignant pleural effusion. This is the X-ray, typical X-ray of pleural effusion, where you can see a white homogeneous opacity with a meniscus on its upper surface, which is characteristic of pleural effusion. Now, there is a Light's criteria of dividing pleural effusion into transudative or exudative. That is, if any one of these criteria is present, the fluid will be either exudative or transudative. For example, so in the Light criteria, which is usually used to discriminate between exudative and transudative effusion, we see the protein of serum and the pleural fluid, and we see LDH of serum and the protein, and then we take the ratios. If the ratio of pleural protein to the serum protein is 0.5 or more than this, it is exudative. And if the pleural LDH to serum LDH ratio is more than 0.6, again it is exudative, or pleural LDH is 2/3 of the serum LDH. Only one criteria is required out of these three criteria to label the pleural fluid as exudative or transudative. Then what is the treatment of pleural effusion? The treatment of pleural effusion is aspiration under ultrasound guidance. This aspiration, it can be for diagnostic purposes or it can be for therapeutic purposes. Definitive treatment is that of underlying cause. Thank you.